Okay, all right. All right, good morning, everyone, and welcome to Geriatric Medicine Grand Rounds. I have the pleasure of introducing a fantastic speaker today, Dr. Jennifer Ray, who I was able to connect with via some shared patients. Really appreciate her valuable insight on patient care. And she is a clinical assistant professor in gastroenterology, and she practices at the Harborview GI Clinic as well as the clinic on the east side, and comes from a training background in St. Louis, which I know we were just speaking earlier about all the special St. Louis connections in our department here. So without further ado, take it away, Dr. Ray.
All right, thanks. Hello, good morning, everybody. Thanks for having me. Happy Good Friday to those who celebrate. Happy Renaissance Act 2 for Beyonce fans. Thanks for having me this Friday. I will be talking to you about common GI disorders in geriatric patients. I see a mix of general GI, but have a focus in motility. So a fair bit of this talk will be about motility disorders relating to geriatric population. I have no financial interests or disclosures for this talk. I broke my talk up into four different sections. We'll kind of hit on all of these different topics today. First, we'll go over esophageal dysmotility. Then we'll move on to anorexia and unintentional weight loss, constipation, and then wrapping up with fecal incontinence and have some time for questions at the end. All right, so first up is esophageal dysmotility. So I had case presentations around each section. So I just made all these up. So Mrs. K is a 73-year-old woman with past medical history of hypertension, diabetes, arthritis, who's coming to your clinic for trouble swallowing. She reports dysphagia to solids and intermittently will have dysphagia to liquids as well. This has been ongoing for for the last year, but with progressive worsening. She also reports some unintentional weight loss of about 5 to 10 pounds and symptoms of heartburn as well. An EGD was ordered and performed, which was normal. So what are we going to do for this young lady? We ordered an esophageal manometry study. And for those who have not seen, my mouse here. Okay. For those who have not seen an esophageal manometry study, it's broken up into three parts, as is your esophagus. So you have your upper esophageal sphincter down here, your lower esophageal sphincter down here. And then this you can imagine is the body of your esophagus in this space here. So this is a swallow that's starting, and this is the contractile force of that swallow. And this is how we measure that number. And this is fairly weak. I'll go over this in a little more detail. This is not going to be a talk about how to read esophageal manometry studies, but just going to show a representative picture. So I'll be talking about age-related esophageal dysmotility. We used to have this term called presbyesophagus or failure of peristalsis in the aging esophagus. And this used to be coined as a tortuous esophagus. Sometimes we would comment on this during our endoscopic exams and reports. This consolates a couple changes, common changes found in the esophagus as we get older. Things that were reported in the past were decreased esophageal contractile amplitude or force in the esophageal body, having polyphasic esophageal body peristalsis or kind of more spastic, uncoordinated peristalsis or muscle contractions, having weak or incomplete lower or upper esophageal sphincter relaxation, and having just a dilated esophagus. With further studies and with time, we don't really use the term presbyesophagus anymore. All these changes that I just referred to were presumed to be secondary to damage from reflux disease. So more studies were needed to kind of take a look into this. So I was able to find some. So how does this occur as we get older? So I have a representative cross section of the esophagus in terms of the longitudinal muscle, myenteric plexus, mucosa, submucosa, etc. So as we get older, we have a reduction in neurons supplying this myenteric plexus, and those will be the driving force for peristalsis as we get older. And as well as the reduction in number of neurons, there is a reduction in the number of myenteric ganglion cells as well. As we get older, we can have an increased smooth muscle thickness, which can affect the force or the efficacy of peristalsis. And then we can also have a lymphocytic infiltration of the myenteric plexus. This is a table I pulled from this article here, going over all the age-related physiologic changes that occur in the GI tract, most of which I mentioned in the esophagus, and we'll touch on the colon and anorectal later in my talk. This is a, sorry, this is in the way. This is a study I found looking at age-related esophageal dysmotility. So this study was comparing 3 different patient populations. One was patients, younger patients, less than 45 years old. The other population was healthy patients over 65 years old for the geriatric population. And then they also looked at geriatric population with having mild reflux esophagitis. And these patients all had esophageal manometry study done, and they were evaluating a couple different parameters. They were looking at the contractile force of the esophagus. They were also looking at primary peristalsis, which is you initiating the swallow and how well your esophagus moves things down. Secondary peristalsis is you not initiating a swallow. It's your esophagus doing a coordinated peristalsis to move remaining food or liquid out of your esophagus that wasn't cleared during the first swallow. And lastly, they looked at lower esophageal sphincter pressures. So they found that there was no difference in the lower esophageal sphincter pressures, nor with primary peristalsis rate across all groups. There was no difference in the DCI, which stands for the contractile force of primary and secondary peristalsis between the healthy and elderly patients, but it was significantly lower in patients with reflux disease, as I mentioned earlier when I was talking about Cressley esophagus. In terms of secondary peristalsis, there was no difference between the healthy elderly nor the elderly patients with reflux esophagitis, but they did find that the rate of secondary peristalsis was lower compared to the less than 45-year-old patients. So overall, they found that aging led to lesser secondary peristalsis, and that acid reflux was a main driver of folks having, elderly patients having decreased contractile force with primary and secondary peristalsis. Another study I found, just kind of answering the question of what are you going to see when you refer patients to your esophageal manometry studies. And what you're typically going to see is a hypomotility disorder, which I see in my clinic quite a bit. So the main ones being achalasia or ineffective esophageal motility disorder. And this is a paper I found. This is a cross-sectional retrospective study of esophageal manometry parameters with aging, and they pulled 930 elderly patients over the age of 60 versus around 240 patients less than 6 years old. So numbers discrepancy, but they at least have a large elderly patient population. They found that with the manometry study, achalasia and hypocontractile disorders were more common than others. You can see in this graph with that being statistically significant. So that's kind of the flavor of what you're going to see. Very briefly, I'll just mention achalasia and ineffective esophageal motility disorder. So achalasia, this is a representative picture of achalasia type 1, where there's no peristalsis here in your lower esophageal sphincter. It's actually tight and is not relaxing with a swallow. So this is a rare disorder where you have loss of the myenteric plexus ganglion cells in the esophageal body. We can see these in 2 different modalities. It's bimodal, so we can see it in age 20 through 40s and also have a secondary peak in the 60-year-old patient population around that age. There's three different subtypes I'm not going to go into. They're managed slightly differently. This disease is associated with autoimmune disorders such as rheumatoid arthritis, lupus, and Sjogren's, although I do see this de novo also without these associations. How do you treat this depends on how sturdy your geriatric patient is. If they are not a surgical candidate or can't get surgical backup, then you want to do the more conservative measurements of those. Those include medications such as calcium channel blockers or nitrates with mixed results. A step up to that would be safe if, again, able to tolerate sedation, would be actually Botox injections at the lower esophageal sphincter to help relax that muscle to allow food and liquids to move through. If your patient can tolerate surgery, we do an endoscopic pneumatic dilation, which is a larger dilation, which we can do with a normal upper scope, or referring to a surgery cutting the muscle here at the lower esophageal sphincter, either endoscopically or with our surgery colleagues. For ineffective esophageal motility, this is the picture again, that's this diagnosis here. It's diagnosed when we have patients do swallows during the manometry test, and we have certain number of parameters for if a swallow is considered weak or ineffective or failed. So we have specific cutoffs for that. It's not quite one-to-one, but it is very strongly associated with acid reflux disease. In fact, up to 60% of patients with acid reflux disease will have ineffective esophageal motility disorder. The esophagus, the main driving force and workhorse of the esophagus is smooth muscle. So you're going to see this in patients who have smooth muscle disorder. So that includes Parkinson's, scleroderma patients. I see this in gastroparesis. Any neurological hit, CNS disorders will also contribute to or can cause an ineffective esophageal motility disorder. How we manage that depends on the severity, again, of the patient. If they can get by with doing conservative measurements, which is chewing their food really well, swallowing and taking breaks in between swallows, chasing the food down with liquids, eating upright, gravity is amazing in terms of just moving things down the esophagus, even if you don't have really strong peristalsis. If they need a little bit extra push, we have a couple different medication options, and these are kind of pro-motility agents for the esophagus, slightly different than treating gastroparesis. And then, of course, if they have acid reflux disease or evidence of heartburn, then you want to treat with a proton pump inhibitor, because studies show, interestingly, that if you aggressively treat the heartburn, then the trouble swallowing actually get better too. Moving on a little bit from esophageal dysphagia to oropharyngeal dysphagia. So we have many contributing factors causing difficulties with swallow initiation, with choking or aspiration. So one is dry mouth or xerostomia. This can be secondary to diabetes, medications, anticholinergics or antihistamines, for example. Neurologic disorders commonly seen in the hospital, outside the hospital, with strokes or Parkinson's disease. They can have some structural causes also, like a cricopharyngeal bar or having an esophageal web at the upper esophageal sphincter. So how we work this up is we work very closely with our speech therapists, who are amazing. We do a good medication review to kind of see if there's any medications that could be contributing to IE xerostomia. And even though it's related to mainly the laryngopharyngeal muscles, we still recommend an upper scope procedure, again, just to rule out any structural causes and take a look at the rest of the esophagus as well. So I have diagrammed here how a normal coordinated swallow works. So you need several different factors. You need to have good teeth for mastication, obviously, the tongue to kind of help move the food bowl surrounding your mouth. When you're ready to swallow, your laryngopharyngeal muscles should contract, your tongue blocks the oral cavity, your soft palate should be elevated from your laryngopharyngeal muscles. Your upper esophageal sphincter, which is normally closed, will open to allow the food bolus to go through. Your epiglottis at the same time will block the larynx to prevent that food or liquid from going into your airway. And then when you're done, the upper esophageal sphincter closes again and is ready for the next swallow. So what happens as we get older? A couple different things. So one is you'll have reductions in pharyngeal peristalsis. You'll have decreased upper esophageal sphincter opening. So if that doesn't open, that food or liquid only has one place to go, which is in the esophagus. The tongue may start to lose some of its driving force. And then you can have retention in the vallecula if you have decreased pharyngeal wall contractions. Also, interestingly, as we get older, we lose our gag reflex too. So all these components can contribute to oropharyngeal dysphagia, and our speech therapy team or great and can kind of help work on some of these things to help strengthen this. So back to our young lady who's having progressive trouble swallowing and unintentional weight loss with heartburn, normal EGD. You refer her to GI clinic. We did the manometry, which I showed you. She had ineffective esophageal motility disorder. We discussed and decided to undergo treatment with combination PPI for her heartburn symptoms and buspirone with good relief, and she's doing much better. Moving on to anorexia now. So this is Mr. J. He's 80 years old. He has a medical history of prostate cancer, COPD, diabetes, thyroid cancer with hypothyroidism, who's coming to a clinic for decreased appetite and unintentional weight loss. About 8 months ago, he was about 230 pounds, but in the office today, he's around 215. He denies any symptoms of abdominal pain, diarrhea, dysphagia, no GI symptoms, and he's coming here with his family who are concerned, obviously, to discuss next steps. So anorexia. So the definition is obviously decreased appetite, decreased food appreciation, some decreased physical activity, which can be contributing to anorexia too. Typically occurs after the age of 70 years old. And we found that this happens to decrease oral intake rather than abnormalities with digestion or absorption, but that's with the caveat with patients not having specific GI symptoms that they're labeling. This happens via multiple different ways. There's social isolation, physical or socioeconomic limitations to access to food. Having dental disease will certainly lead to decreased appetite and food appreciation, changes of taste and smell sensations, and then cognitive decline as we get older. In terms of the pathophysiology of anorexia, it's multifactorial. We have our hunger hormones that come into play. So that's with central feedback via the hypothalamus, and that regulates the input from ghrelin and leptin, our hunger, and early satiety hormones and other nutrients kind of play into effect. Taste buds actually go down or decrease as we get older and become atrophic. So we lose salt and sweet first, which would make me very sad because those are my favorite. We also have decreased salivation secretion as we get older. So that leads to decreased ability to dissolve foods, which can affect their want to eat. Sometimes we can see altered gastric motility with decreased fundal accommodation, so top of the stomach, lack of stretching to allow food to kind of hang in there. And that occurs with reduced nitric oxide secretion. And sometimes you can see delayed gastric emptying. So again, depending on your patient population, you might want to screen for this too. The unintentional weight loss component, that's greater than 5% loss of body weight in a 6 to 12-month period. It's obviously closely tied to anorexia. Most common are non-malignant, but you obviously have to be concerned for that too. Cachexia syndrome is the same unintentional weight loss definition, just associated with a chronic illness. And you can see reduced muscle strength, low albumin, low anemia, and low fat-free mass index also. These are different causes for weight loss and aging. So you have the social, which I mentioned previously, that's ethnic food preferences, lack of resources, medical, GI obviously playing a strong component of that. You can have cancers, endocrinopathies, medications as a potential cause, and then psychological dementia, cognitive decline, or alcoholism. Hopefully not in all these populations, but we definitely do see that. How do we work this up? So great history and physical is the primary key. So we focus on assessment of cognitive impairment looking for depression or issues with functional status or ability to get food, and then focus on common symptoms to try to see if there's any underlying chronic illness kind of contributing to that. Obviously, paying attention to the GI tract with dysphagia, dyspepsia, indigestion, abdominal pain, fever to suggest some chronic inflammatory disease or dyspnea. Look at medications. So I pulled this table here. I'm not going to read all those to you, but those are some medications that can contribute to weight loss. And then pending studies and surveillance and imaging and labs, a diagnosis can be found in about 2 years of initial presentation to hopefully help regaining weight. I wanted to mention this because I see this a lot endoscopically in terms of people being referred for weight loss. This is a study I found looking at patients being evaluated for unintentional weight loss with upper and lower scope. And they found that overall, if there are no alarm symptoms, which I listed there, the yield of finding organic etiology in the GI tract is actually pretty low. So this is a respective cross-sectional analysis I found looking again for patients with weight loss, and they're mainly wanting to look and see if they found anything endoscopically. And they found that around 160 patients around age 61 years old, they found like a 9.7% weight loss from baseline. These folks had normal labs and normal imaging in 98% of patients, and they found basically nothing in the upper scope and the colonoscopy. So the conclusion or bottom line is if your patient doesn't have alarm symptoms with GI or GI focused symptoms contributing to their anorexia or weight loss, and they have normal labs and normal imaging, I would maybe consider holding off on ordering a scope because we're likely not going to find anything in their sedation risk. So back to our patient, he had basic labs drawn, which were all normal. A CAT scan, pan CAT scan was normal. On further review, he reports a recent loss in the family, resulting in depression, resulting in anorexia. As such, an endoscopic evaluation was deferred. All right, moving on back to motility land, moving to constipation. So this is Mrs. H. She's a 76-year-old woman with past medical history of diabetes, hypertension, and cholesterol, Parkinson's disease, who's coming to primary care geriatric clinic for worsening constipation. She reports having chronic constipation most of her adult life, but it's definitely gotten worse in the last few years. Previously, she treated her constipation with high fiber diet. However, now she feels more bloated and having actual decreased stool frequency. She started adding Miralax with some improvement, but she's coming to see you in terms of next step because Miralax is not cutting it. She denies any significant alarm symptoms such as weight loss, rectal bleeding, or abdominal pain to warrant a colonoscopy. I didn't put this in my case presentation, but I'll just say she had a normal colonoscopy 2-3 years ago. All right. So constipation in the elderly. Sorry, I don't know if I can move this. So this is one of the most common GI symptoms or complaints I see in clinic in the elderly is constipation. It's occurring in up to 20 to 40% of patients, and definitely increases as we get older, especially in women, but I can see this in men also. Definition of constipation. So that's decreased stool frequency, i.e. less than 3 times a week. Having hard stools. I didn't put the Bristol chart up here, but it's the GI's favorite tool. So pulling up the Bristol chart and having patients kind of help show you what type of stool they're having. And if they're having hard Bristol-like one stools, which are pellets, or lots of lumps and cracks, that's more suggestive of chronic constipation. The need to strain, which is more commonly in the elderly population, and just feeling a sense of incomplete evacuation. They go to the bathroom, they have a bowel movement, they feel like they didn't quite get everything out. This can be secondary to organic disorders listed here. So for the colon, you can have inflammatory bowel disease, which can cause constipation. More commonly, we think of diarrhea, but people can present with constipation and have inflammatory bowel disease. Malignancies would be something to be concerned about in the colon. Endocrinopathies with low thyroid disease or hypothyroidism. Diabetes, this is the most common bowel disorder or bowel symptomatology we see in patients with diabetes is constipation. Neurologic disorders, Parkinson's, stroke, and physical activity. Again, from the distal 2/3 of your esophagus down to your anus is all smooth muscle. So anything that's going to affect smooth muscle can definitely affect GI motility. Medications are things we do to the patients. So calcium channel blockers, I do a good medication review to make sure that they're not on high doses of these, or beta blockers. Antispasmodic, such as bentyl, dicyclamine, or leptin, hyoscyamin. Those work good for periodic abdominal pain, but if the patients are taking them a lot, they do have a constipation side effect, similar to Zofran, actually, for anti-nausea. And then polypharmacy, which I know we're good about in geriatric clinic for screening for that. But that's something we kind of have to look at too, because all those things in play will definitely affect the GI tract motility. If you're not finding any organic disease, it could be secondary to a functional constipation or a defecatory disorder, such as a rectocele or dyssynergic defecation, and I'll discuss that more in detail. Aging and the GI neurologic system. So for constipation in the colon, not much is known about neuromuscular changes as we get older. I found a few studies that looked at kind of histopathology as we get older, and they found that we have decreased interstitial cells of Cajal. And these are throughout your entire GI tract. Those are the pacemakers of the GI tract. They send electrical stimulation to help move and uh, contribute to peristalsis. So having loss of those could cause slow motility or slow transit constipation. Collagen deposits similar to the esophagus with lymphocytic infiltration can have collagen deposition in the colon, increases with age, and can result in decreased or altered motor function, and also compliance of the colon in terms of being more stretchy to allow more stool to fit in there. Histological analysis shows that there are degenerative changes in the smooth muscle too, which can also affect and cause slow transit constipation. So elderly patients will often describe needing to apply abdominal pressure to help with having a bowel movement, the sensation of a blockage or perianal obstruction, and the need to use digitation or manual disimpaction to help get stool out. Risk factors for that is if they're having malnutrition or a really low fiber diet. Obviously, you have to be concerned about cancer, looking at social factors too. For evaluation, rectal exam is really important, and I'll go through that more in the fecal incontinence section. I would refer for endoscopy analysis if there are significant alarm symptoms or they haven't had a colonoscopy for a very long time, just to rule out cancer or obstructive causes. And that would be, things to be concerned about is new onset constipation would be concerning if they're having rectal bleeding, unintentional weight loss, as we previously mentioned, a family history of colon cancer or having new iron deficiency anemia. That would be when you want to look and do a colonoscopy for evaluation. So how do we work this up? Looking at basic electrolytes, calcium, having hypercalcemia can contribute, looking at thyroid disease, looking and assessing for dietary fiber. So the caveat with this being in someone who's having very, very mild constipation, you tell them we recommend typically a very high fiber diet, 25 to 30 grams of fiber a day, which is granted a lot of fiber, but that's what we recommend. However, if as we get older and we lose these peristalsis effects, the more fiber you add, the more bulk you're adding to a system that's not moving, and your patients will not feel good. They will get more bloated, feel like their constipation is worsening, like our patient that we mentioned. If persistent symptoms, I start always low and slow, starting with over-the-counter laxatives like Miralax or Senna. Stool softeners such as Docusate we found is not effective in treating constipation, so we actually don't recommend prescribing those anymore. If they're not having improvement, this is when you want to get your GI colleagues on board to consider some diagnostic testing and maybe step up to secretagogue therapies, which I'll mention next, such as Linzess or Amitiza. The diagnostic testing for constipation is colonoscopy, as I previously mentioned. We can do things like a SITS marker study, which, if you've not heard of that before, is a one big pill that has 28 radio-opaque markers inside. The patients swallow those. We have them hold their constipation meds for 5 days for the study. And they get x-rays on day 5 to see how many of those markers are left in the colon. If it's greater than 5, then they have colonic inertia, which is a form of extreme severe full transit constipation. Anal rectal manometry testing, and I'll talk more about this later, but that's looking for defecatory disorders or dyssynergic defecation, aka pelvic floor dysfunction, contributing to constipation. MRI defecography can be used to look for an anatomical abnormality, such as a rectocele, which can cause a pseudo-obstruction, as well as other obstructive etiologies in terms of contributing to constipation. I would recommend avoiding surgical treatment of constipation if possible. I do have younger patients around like 40 to 50 years old who are fed up with their constipation, failing all medications, and just want to bypass their colon. That you can do that in the elderly, but obviously you're not a surgical candidate. Is definitely a more tricky procedure to do. So secretagogues in the elderly. So for those who did not know what these drugs are, so drugs listed here are lubiprostone or Amitiza, Pacanitide or Trulance, linaclotide or Linzess. Another drug I didn't put on here is Motegrity or Prucalopride. These are all medications designed to help increase peristalsis, primarily in the colon. Motegrity works more for the whole GI tract. How it works is it activates the chloride channel in the colon to increase chloride secretion and thus bringing in water. And this will activate peristalsis. So unlike the over-the-counter laxatives that are just drawing water into the colon to help have a bowel movement, this is the added benefit of increased water secretion and increased peristalsis. So it helps kind of dry that stool out. It's mainly studied in younger populations for irritable bowel syndrome. These are your drugs for IBS and also for chronic idiopathic constipation, but they're safe in the elderly. I do these a lot. Of these medications, I typically start with Amitiza. It's a twice a day medication. The most common side effects is nausea and diarrhea. So of these medications, Amitiza is the gentlest one, I would say. I don't want patients to have blowout diarrhea. I tell patients give themselves about a week for their system to get used to the medication because the diarrhea is pretty common to happen up front, and take the medications away from food because food is more activating when you take it with the medication. Linzess, I reserve for more severe constipation. That medication is stopped up to 20 to 30% of time because of explosive diarrhea. It's a real butt kicker. So I don't typically start with that medication in terms of constipation for my elderly populations or for my younger population. So stick to Amitiza, twice a day dosing. They can drop it to once a day too if they need to, which is an added benefit. All right, anorectal manometry testing. So I order this test a lot. This test is amazing. So for those who don't know what that is, it's a catheter that's inserted just across the anal sphincter into the rectum, has a deflated balloon attached to it. And we have patients do certain parameters. And the main thing we're looking at is pelvic floor dysfunction and the anal sphincter pressures to see if there's any pelvic floor abnormalities. So we can test a lot of things. I refer these patients for folks who are having diarrhea with incontinence or constipation issues to see if what's going on here. So it measures resting and squeeze anal sphincter pressures. It looks at the length of the anal canal, which can be shortened if prior surgeries. It looks for the intrinsic reflexes of the internal anal sphincter of the myenteric plexus to see if there's any suggestive neuropathy there. It can look at the pelvic floor and anal sphincter coordination with defecation. So what's supposed to happen is your pelvic floor muscles are supposed to relax and your anal sphincter is supposed to open as you have a bowel movement. And sometimes that coordination gets out of whack. So we can measure that real time by having patients strain or push like they're trying to have a bowel movement. And then you can look for symmetry of the anal sphincter to see if there's any significant abnormalities for, i.e., fecal incontinence, to see if you need to do further workup there. If they have significant abnormalities, I refer them to pelvic floor physical therapy with biofeedback. Patients can have pelvic floor physical therapy without the testing. However, that's not going to be specific for their constipation causes, but they get referred for, i.e., urinary incontinence, or sometimes just get referred for constipation without the testing. But biofeedback is really nice because we can actually pull this test up and do real time changes with the physical therapist and say, oh, this is what you're doing, this is what you need to be doing, and they can see that and get that corrected real time. So this is a representative picture, looking at anal sphincter pressure down here and the rectal pressures, which should be lower, obviously, because the rectal is kind of a bag and more open, it induces less pressure against the balloon catheter. So with squeeze, you're supposed to see an increase in rectal pressure as stool is being driven out or things are moving down, and you're supposed to see a relaxation here. So I think this is a weather map. This is a high red zone, so stronger force. So this is actually a paradoxical contraction here. Oh, I'm sorry. This is for, sorry, I confused these two. So this is what would be abnormal if you were trying to bear down and you had increased anal sphincter pressure. For this is a squeeze, this is normal, sorry. So when you have the patient squeeze around the catheter, you want to see a nice strong force here. This is considered normal when you bear down or push. You're supposed to see a green-blue relaxation of the anal sphincter muscles here. If this were to happen over here, that would be abnormal. That would be pelvic floor dysfunction. So back to our young lady with constipation and Miralax is not cutting it. Due to worsening symptoms, she had another colonoscopy, which was normal. The patient was stepped up to Amitiza twice a day with improvement, however, still having some constipation. So she was referred to GI clinic where she had an anorectal manometry test, which showed dyssynergic defecation or pelvic floor dysfunction. She was sent to pelvic floor physical therapy with biofeedback and had significant improvement in her constipation. Last but not least is fecal incontinence. So this case presentation, this is a 68-year-old woman with hypothyroidism, hypertension, chronic constipation, who's coming to you for worsening fecal incontinence. This has been intermittent stool smearing throughout the years, but it's definitely gotten worse in terms of frequency and the amount. It occurs mainly with coughing or sneezing, so kind of stress. She has a normal history, and I always ask this for my female patients of what happened. Did you have children and what happened with those deliveries? So she had 3 vaginal deliveries, 2 of which resulted in episiotomies or tears. And she is treating her constipation with Miralax. So fecal incontinence, we have 3 different subtypes here. One is passive, which is unintentional. Patient's not aware that's happening. That's more of a neurologic disease. Urge, having the attempt to retain stool but inability to make it to the restroom. And then seepage after defecation, which is more associated with pelvic floor dysfunction. Fecal incontinence is very strongly tied to diarrhea or constipation, and often treating this underlying issue will help with the fecal incontinence. So making sure to ask about constipation or diarrhea. Risk factors is as we get older, a couple things happen. So this is a side view in a woman of pubic bone in the front, tailbone in the back, rectum here. This is the main pelvic floor muscle. There is a series of pelvic floor muscles that's as a bowl to support the urethra, the vaginal canal, and the rectum here. So you can have a weakness in anal sphincter, resting and squeeze pressures. You can have lower rectal compliance, which if we can't hold stool, it's got to come out, and altered sensation with altered anatomy here. For vaginal women with vaginal deliveries with tears, even plus or minus tears, and who are multi-parentous, more than 1 kid, had an obstetric injury, that's going to put you at risk for getting fecal incontinence later. Neurologic disorders, common theme that we discussed previously, more for passive incontinence. Decreased mobility in terms of more urge, fecal incontinence, social barriers. And then IBS, which I do see sometimes in my elderly, but it's definitely less common. This is the rectal exam, which I do in the office where folks come in with incontinence or constipation, because you can get so much information out of there. So I document all this in my note. So you can take a look at the surrounding skin. Is there any skin tears, breakdowns? Can you see an anal fissure? Swiping your finger across the anal sphincter, looking for the anal wink. This is looking at the S2 to S4 reflux. And if that reflex isn't there, then that suggests pudendal nerve neuropathy. Skin tags, hemorrhoids, I mentioned, you can see, is there stool in the rectal vault? Is it liquid stool? Is it hard pellets? For men, you're looking for masses. Also in women, for prostate exam, excuse me, in women, you can look for kind of masses too, or feel for that, more distal masses. You can assess for tenderness. If your patient is not letting you insert their finger at all, it suggests an anal fissure, or it could suggest a muscle spasm, defecatory disorder. And then do a functional assessment. So I just take a look and feel how the sphincter tone feels at rest. I have them push like they're trying to have a bowel movement, and you're supposed to feel the pelvic floor descent and the anal sphincter relax slightly. If you don't feel that, that would suggest some dyssynergic defecation. This is a great paper I found with kind of a workup for fecal incontinence. So I always do a rectal exam, so I wouldn't necessarily separate this. So if you have you do a rectal exam and they're not having any diarrhea or constipation, if it's abnormal and you're concerned for dyssynergia, you're going to do an anorectal exam. If you have decreased rectal tone or, God forbid, a gaping anal sphincter, you're going to be concerned for neurologic disease and do appropriate imaging and referrals for that. If you see significant rectal prolapse, before I insert my finger, I forgot to mention, I just have them push to see if prolapse is happening. Then you want to look at an MRI for structural causes and refer to surgery. If your rectal exam is normal, look at removing any medications, any dietary aggravators, add some fiber and kind of help bulk up the stool. If no improvement, do additional testing. If constipation or diarrhea, work up the constipation, diarrhea, and if not improvement, do all these things. Over here. This is an MRI. So the test is not fun to do. The patients have to lay on their side with a diaper. The radiologist will insert barium enema from below to kind of look and see if there's any significant pelvic floor abnormalities, look for any structural abnormalities. So things we see here is prolonged and incomplete evacuation of contrast. This anal rectal angle, so at rest, this pelvic floor muscle is pulled tight against the pubic bone here. And when you relax, with the pelvic floor is supposed to relax, and this anal rectal angle, this angle here is supposed to get straighter to allow stool to go through. So if you see a less than 20% degree change in that, or a paradoxical decrease, and that's abnormal. The anal canal, you can look at descent of the pelvic floor past this pubococcygeal line. It can be excessive, which can cause a pseudo-defecatory disorder. I put the parameters here. Looking at presence of rectal cells, which is the bulging of the rectum into the ureter space. You can see persistocyls or enterocyls, which could be contributing to pseudo-obstruction. For more severe cases, you're going to refer to surgery. I use this test in combination with the anorectal manometry test for pelvic floor dysfunction, if I'm highly concerned about an obstructive etiology too. The anal endoscopic ultrasound is also a great tool for looking at fecal incontinence. So this is best test for looking at anal sphincter injury. We can find defects, with the most common being the external anal sphincter. You have two sphincters, internal and external anal sphincter. And EAS defects are more common. So we can see scarring, we can look for defects, changes in thickness or tears. And this is done with our advanced endoscopists who do EUS procedures. If there are significant abnormalities that you can't quite get under control with pelvic floor physical therapy, biofeedback, or with medication adjustments, then you want to refer to surgery for evaluation. So this is the surgical management for fecal incontinence. Again, the external anal sphincter is the most common etiology of fecal incontinence, and it's treated with sphincteroplasty, which is essentially overlapping muscle over the external anal sphincter defect. Short-term results, that it works really well. The effect is sort of gets lost a little bit, as with time, as with most things. And this is presumed due to additional external sphincter defects that may occur. In terms of looking at this surgery in elderly populations, the outcomes aren't as great. And if you're having severe incontinence, the outcomes aren't as great either. But the surgeon will kind of go over, all the options in terms of management of fecal incontinence. Bulking agents is something I have my elderly patients do quite a bit. So this is a biocompatible gel that's injected into the anal canal / perianal region, about 1 to 2 centimeters above the dentate line, which is the separation of your smooth muscle tissue and then your squamous tissue from the anal rectal angle or anal rectal space. So 50% or more have reduction of their symptoms with low side effects. So it actually works pretty well in terms of your other mechanisms to help treat fecal incontinence. Sacral nerve stimulation is a temporary stimulator that's placed in the subcutaneous buttock / lower abdominal wall. And if the patients do well after 3 weeks in terms of helping to provide some extra oomph for any neuropathies in terms of the anal sphincter muscles, then a permanent stimulator is placed. And it's effective for folks who've had prior rectal surgeries and for sphincter defects as well. Last but not least is the colostomy. So we certainly see this on the inpatient side of things in terms of patients having, i.e., severe sacral decubitus wounds and chronically getting infected because stool is in, constantly in the mix. And they have decreased mobility. So they often get a diverting colostomy. I reserve this for severe disabling incontinence and kind of for those risk factors that I mentioned, but they get, significant improvement in quality of life as a result of this. Things are allowed to heal up and they're not, bedridden with their incontinence and have better quality of life. But again, only for severe patients. I don't recommend obviously doing this because that's a big surgery for our elderly population. So back to our patient with incontinence. So an anal rectal manometry test was done, which showed weak rest and squeeze anal sphincter pressures with stool. I'm sorry, that was a rectal exam with weak rest and squeeze anal sphincter pressures with stool in the rectal vault. She had an anorectal manometry test, which confirmed this and showed an asymmetric anal sphincter. The patient was referred to pelvic floor physical therapy and was told to increase her fiber to help add some bulk to the stool, and started on Linzess to kind of help give and treat the constipation more effectively. That helped a little bit, but she was still having some incontinence episodes. So due to asymmetry of the anal sphincter, an EUS was performed, which confirmed an external anal sphincter injury with asymmetry, and the patient was referred to surgery, was treated with a bulking agent, and got better. So in summary, we reviewed evaluation of esophageal and oropharyngeal dysphagia. Most common esophageal motility disorders in the elderly are ineffective esophageal motility disorder and achalasia. We assessed the etiology of anorexia and unintentional weight loss. If everything's normal in terms of your workup with labs and imaging, consider holding off on endoscopic evaluation in the setting of lack of GI symptoms. We discussed pathophysiology and management of constipation in the elderly, reviewed the anal rectal manometry exam and the all-important digital rectal exam, and we explored the workup and management of fecal incontinence in the elderly. I'll pause for questions. That's my QR code for evaluation. I'll appreciate any feedback. Thanks.
Thank you so much, Dr. Ray, for your fantastic overview. There are a few questions in the chat. I'm wondering if you could see them or if you'd like me to read them to you.
Let me see. Oh, so okay, yes, thanks for your questions. So, anal rectal manometry and pelvic floor therapy in persons and people with moderate dementia with fecal incontinence. Obviously, it depends on how severe is the dementia. If it's severe, it's going to be less effective, obviously, in terms of retention of doing the physical therapy exercises. So our further physical therapy, we have patients obviously go to meet the therapist for the first time meeting. If they're functioning at home and can get help, they can do home physical therapy exercises or with their family member. But if they're severely, having severe dementia with fecal incontinence, same for my younger patients I have who have like trisomy 21 disorder or cerebral palsy. This isn't necessarily a test I can perform, unfortunately, because of lack of retention of knowledge, for various reasons. So if they're having severe incontinence, I would just do what workup you can in terms of that, and then consider referral to a surgeon if you can't treat the underlying constipation or diarrhea effect. How often are the bulking agents needed? So I use this if I can't quite get control with medical management and conservative management. So I try my hardest to, look for any pelvic floor dysfunction and do pelvic floor physical therapy, and to treat with medications. If they're having severe diarrhea, adding fiber to help form up the stools, anti-diarrheals to help slow things down, give the water a time to, not evaporate, but to consolidate the stool to help add form to help the incontinence. For constipation, it's adding a touch of fiber, not too much, or having really bad slow transit and increasing the constipation meds. If I can't get a hold of that, the most common thing I ask the surgeons to do is a bulking agent. Obviously, I have to defer to the surgeons. I'm in concert with them a lot. We have good discussions about how to best manage a specific patient, but I tend to favor the more bulking agents. We used to have um, kind of a probe or a plug to help with anal for fecal incontinence, but that's kind of gotten out of favor because it doesn't work as well. So I use the bulking agents kind of as next line.
Dr. Rate, one question I had is I've had some patients try the Linzess and Amitiza, and sometimes it's hard for me to get a good sense from their history based on various factors if it's effective. So I'm curious if someone is consistent in taking it, what period of time would they have to be taking it consistently before you would actually notice a significant change in their symptoms?
Sure. So when I'm prescribing these medications, I tell people take the first dose, be at home. Like typically for folks who get in a rhythm of taking the medications, they take the medication and then 2 3 hours later they have a bowel movement in like a good success patient. But I tell people, especially with Linzess, they're going to get diarrhea. So I just tell them, don't take it and go run to the store. Don't take it and go somewhere. Stay at home. And they should know within a week or two if it's going to work. And how I ask patients in clinic for follow up is how the medications are working. Is does it help increase their stool frequency if that was part of their primary concern? For me, I don't necessarily need to see increased stool frequency. What I really look at is when they have a bowel movement, do they feel like they're getting everything out? And when they have a bowel movement, they feel like they have to strain or push. If they're still having to do straining, pushing, and they feel like they're still not getting everything out, I still have more work to do. So kind of dose titration or doing additional testing. So that's kind of how I query that in terms of my clinic follow-up.
Thank you. That's really helpful. I think I'd been asking about frequency and not so much about the straining, so that's really helpful. Um, there's a few more questions in the chat. There's one from Kay about the ultrasound prior to bulking agents?
Yes. So I do all my workup I'm going to do before I do the definitive measurement, just because if you want to do like more testing post to see like if there are still issues, you need to get a baseline test prior to that. So yes, I would do your MRI echocardiography or your anal endoscopic ultrasound, depending on the clinical scenario, before you do the definitive defect. We GI orders that. So if you're getting into MRI echocardiography land and endoscopic ultrasound, you probably want to get your friendly gastroenterologist on board too. What are key factors that would lead a PCP to consider microscopic colitis in older patients with diarrhea? So that's a good question. So for microscopic colitis, I do a good medication review for folks who have been on chronic PPI therapy for a very long time. That increases their risk of having diarrhea. Look for obviously any other medication causes that cause diarrhea, concern for any inflammatory disorders such as having fevers, chills, any blood in the stool, looking for diet being the main big question I ask, if they're eating a lot of candy, sugars, no alcohol, hopefully not. Looking for risk for like bacterial overgrowth syndrome. If the diarrhea is significant or, it's been ongoing for years, affecting quality of life, and they really haven't had that test, in addition to my other lab stool study workup, I will go ahead and add a colonoscopy for microscopic colitis because they're at risk for that as we get older too, especially with the medications. So medications are PPIs, NSAIDs, and SSRIs. Those are the common medications that can cause microscopic colitis. And that's only diagnosed via colonoscopy with biopsy. You can't, there's no blood test I wish to diagnose that. You have to make them do a colonoscopy and get random colon biopsies. Any other questions?
We take care of a lot of patients who are surgical patients in the hospital. We do a lot of co-management or consults with surgical services. And for folks who are on meds like Linzess, where we won't necessarily, sometimes we can't even give them in the hospital, but do you have any recommendations for that setting when someone's hospitalized and chronically on these meds? Anything we should be worried about with stopping or starting them?
No, I mean, but the main side effects I mentioned are nausea and diarrhea. So I think if they were on them as an outpatient, you can continue them as an inpatient, maybe. I believe I haven't actually had a patient on Linzess or Amitiza like be hospitalized. Well, actually, it's been a while, so I can't remember off the top of my head. I'm sure I have actually, but if it's not affecting any inpatient needs, I would continue the medication because it's hard to get that same Linzess effect with what we have in stock in terms of like Dopalax or Miralax or anything like that. If you need a medication that would help increase peristalsis and we can't get those medications, if they're on opiates, hopefully not, you can do Relistor. I think you can get Movantik in the hospital. There's also other medications like Critosigmine or Bethanacol, but if you're getting into that territory, you would probably get GI on board to help out with that. But if they're able to continue it inpatient and it helps them with their symptoms and there's no, contraindications, which there really aren't really for continuing that medication just to help with constipation. It doesn't cause any electrolyte derangement. There's no drug interactions. It's a very safe medication. Just diarrhea.
Great, thank you so much.
Mm-hmm.
All right. Well, I want to respect everyone's time. We're at the hour, and we have appreciate all the great um, questions from everybody and all of your great teaching, Dr. Ray. I learned so much today.
Thank you so much. Thanks for having me.
This is awesome. Thank you so much.
Oh, sure. Absolutely. Thanks.